That's assuming that we are.
We can.
Thank you, Emma. So as Emma mentioned, my name is Gareth Davies. I'm an emergency medicine consultant in Hampshire Hospitals, so work in Basingstoke and Winchester. And today I'm going to talk about the UK REBOA trial. So as Emma mentioned, I couldn't get away with not mentioning my podcast. It's a fairly new thing that we've been doing this year. It's supposed to be a sort of a good way at looking at clinical cases that we present in our governance meeting every month. So we have a deep dive into sort of exciting, weird and wonderful cases and things that may not have gone so well. And we sort of use that with a bit of lightheartedness, dad jokes every now and again as well. So it's available on Apple, Spotify, and all the other podcast channels. So have a look at that. So what we're going to talk about, well, I guess we need to start off with what REBOA is. So it's resuscitative endovascular balloon occlusion of the aorta. And we're using this in the context of trauma, and that being bleeding. Bleeding in the abdomen, that's either from a penetrating trauma or a blunt trauma. And it was conducted in the UK. So just to mention, actually, the first REBOA pre-hospitally was performed in the UK, and that was performed by the HEMS team from the Royal London. And that was probably around the same time I heard about it. Now, I must just have to tell you that I'm not Gareth Davies, who was the clinical director of HEMS, so I apologize about that. And I also need to mention that I'm not Gareth Southgate. If anybody's interested in football, there's a competition going on at the moment called the Euro 24, and England will be playing tonight in the semi-finals. So I know I'll be cheering them on, but I'm afraid I'm not the manager of England. So a bit about me. Well, excuse me, gone past. Sorry, I'm going to go back. So unfortunately, I've not done REBOA, but I reckon I could. I'm practicing a UK emergency physician. I've worked in trauma centres both in the UK and overseas. Most of my training was in Stoke-on-Trent, which was one of the major trauma centres in the UK. I also spent 2 months in Chris Hani Baragwanath Hospital in South Africa. If anybody's interested, I've got plenty of war stories about that. I must have seen most of the things in the ATLS manual. And I've placed plenty of cell dinger devices, but never a REBOA, but I really want to because it looks cool. So why are we even talking about it? Well, I think Karen Broe sort of summed it up at the time when REBOA was first introduced into the HEMS team. And he's a consultant vascular trauma surgeon at Barts, where the Royal London is. And he sort of summarized it into we need to stop patients or people bleeding to death. It's one of the world's biggest killers. Over 2.5 million people bleed to death from their injuries each year around the world. And this is why HEMS in London wanted to try and come up with a new strategy to reduce that death toll. So REBOA was viewed as one of those strategies. So what is it? Well, it's essentially a catheter that goes into the femoral artery and then is inserted right up into the aorta in the abdomen. And it can go up right up to the top of the abdomen. And then a balloon is inflated, and the idea being to stop the bleeding distally. It's found in a sort of pack that you might find in any sort of aseptic tap. So, for example, a cell dinger central line kit or a cell dinger chest drain or an arterial line. It's the same sort of thing. You'd find it in a little pack that you get. And that's what it looks like. So you get the catheter goes in, you inflate the balloon, and then that will sit in the aorta. And as you might expect, to perform this procedure, it needs to be done aseptically and usually with ultrasound. Like most things these days, we'll be using point of care ultrasound to introduce this. So it was published in JAMA in 2023, and it was called the UK REBOA RCT. So design. So if we talk about internal validity, like my colleagues have already done, so we know that this was a multi-center control trial. So this was 16 trauma centers throughout the United Kingdom. It was open label, so it wasn't blinded. And for reasons that might be obvious, it's quite difficult to blind a procedure like this. It was conducted between 2017 and 2022. A few other things to talk about in the methods that are not on the screen. This was an intention to treat analysis, so everybody was included. Consent was not required, but was gathered later. In fact, consent was difficult because most of these patients were critically ill and weren't able to consent. So it was conducted under a sort of capacity assessment. Allocation was concealed as well through a web-based randomization. So really good things and a few not so good things in the internal validity. So as I mentioned, there were 16 centres throughout the United Kingdom. So a good spread across England. So the Royal London, for example, in London, a few other hospitals in London, some in the West Midlands, so for example, Birmingham, and some up into the north, so including Hull, and then some in Oxfordshire. So what was the intervention? So this was REBOA versus standard care. And in fact, I should say that's not quite true. It was REBOA and standard care versus standard care alone. So what do we mean by standard care? So we're talking about everything you might expect when a major trauma patient arrives in your resus bay. So that will include the formation of a trauma team, the conduction of a rapid sequence induction if necessary, the use of major hemorrhage protocols, and the use of invasive central lines, for example, subclavian lines. So the population. So the inclusion criteria were these were trauma patients over 16, so no children were involved in this trial, with suspected or life-threatening torso hemorrhage that was deemed amenable to adjunctive therapy with REBOA. And that was assessed by the trauma team leader in that resuscitation, so experienced emergency physicians. Exclusions were that of pregnant women and injuries that were deemed unsurvivable. Some of the baseline characteristics which aren't on this slide, just to give you a flavor of what patients were in this trial. So 69% of them were male. 97% of these patients were blunt trauma, which I think is a little bit more specific to the UK. So most of these were things like RTCs rather than stabbings and shootings. And the median age was around 41. Patients, so 90 were randomized, 46 were randomized to REBOA and standard care, and 44 were randomized to standard care alone. So as you can see there, just a little chart then to sort of highlight what we've talked about. But as you might see, not everybody that were randomized actually received the therapy that they were randomized to. So as you can see in the REBOA arm, 46 were randomized, but actually 19 of them didn't actually get the catheter inserted or the balloon inflated. So another thing that might reduce the internal validity of this trial. So a brief talk about the zones. So as you might expect, not every patient is bleeding from the same blood vessel. So you don't want to cut off the entire abdomen if you can, avoid it. So zone 3 would be quite distal, so really at the bifurcation, zone 2 in the middle and zone 1 at the top. So if we can try and avoid cutting off blood supply to all of those organs if we can, then that's why we have zones. So the randomization, as I've already mentioned, it was a 1-to-1 ratio, and the randomization was either to REBOA with standard care or standard care alone. And it's just notable that they used a web-based system and they used block system. The randomization was actually used using phones, so their mobile phones at the time. And looking at the trial, that was quite good because they were able to randomize the patient within seconds of them being assigned. So the outcome, and I know that's not quite clear at the top, but the headline is mortality was higher in the REBOA group. So the primary outcome being 90-day mortality using REBOA and standard care versus standard care alone. As you can see, around 54% of patients died in the REBOA arm versus 42% in the standard care alone. So there's a little graph, and this was, so probability of survival, and that's hours to days, and that's comparing standard care alone and REBOA and standard care. And as you can see, standard care alone is higher, and that's your probability of survival increases. So there were some secondary outcomes, and as you can see, these are all around mortality. So 3-hour mortality is higher in the REBOA group, 6-hour increased, and death within 24 hours increased. One of the other things that was notable in this trial was the actual delay to definitive hemorrhage control. And we know that most of these patients who have life-threatening hemorrhage will need damage control surgery. So the point of the authors noted that actually there was a delay in getting to that damage control. And so we noted that 83 minutes versus 64 minutes. The authors already also mentioned that the people performing this procedure were emergency physicians, not surgeons. And we know surgeons will be the people actually taking them to the theatre. So the conclusion, unfortunately for REBOA, was that in trauma patients with exsanguinated hemorrhage, a strategy of REBOA and standard care in the emergency department does not reduce and may increase mortality, which is unfortunate because I actually quite liked the look of it. So some of the strengths, well, as my colleagues have already mentioned, how do we assess a paper? We talk about internal validity. Now, it's notable that actually this was an intervention that had previously been described as life-saving and a game changer, so it was important that we look at this. There was allocation concealment, but unfortunately the randomization wasn't blinded, as we know, because it's quite difficult to blind an invasive procedure like this. It was intention to treat, which improves internal validity. And I think it's a good study that because it will inform trauma-based care in advanced trauma centers. So some of the weaknesses. So as I mentioned before, this was done by emergency physicians, and I think the point was that could something else be done? Could this be started in the theatre, for example? Could we be using it at the same time of prepping for theatre? It was unblinded, as I've mentioned a few times, and we know that would be impossible to achieve in this trial. Also mentioning that the fact that less than 50% of these patients who were randomized to REBOA had a REBOA inserted inflated. So it's quite a lot of drop off there. Now, I know we had a primary outcome and we had secondary outcomes, but there was no mention about some of the complications that you might expect from REBOA, for example, ischemic lower limbs or renal injury. I think it's important that we know that these things are out there and to what extent they are being used or produced. So I think overall, this is a great trial. It has a good internal validity from the fact that it was multi-center. I think it was an intention to treat, so everybody was included. From an external validity, I think it was, from my point of view at least, it was a UK-based trial. It was generalizable to a population that I see, but may be different to what other people see. For example, in other countries, they may see patients with penetrating injuries versus blunt injuries. This is something I could see myself doing. It would probably be quite easy to learn. And I note in the trial, the emergency physicians involved went over a 2-day course to learn it. So it was quickly learned because most of these consultants would have done invasive procedures like me in the past. So in summary, it was a randomized controlled trial, and it did show that REBOA, unfortunately, did increase mortality. So I think there probably will be other trials in the future, certainly in the context of maybe centers that don't have access to damage control surgery immediately. This may be use in that context. So thank you very much, and I look forward to any questions.